I'd like to invite Dr. SOMASHEILA MURTHY. She's the dynamic cornea surgeon, HOD of LVP cornea department, and she would be speaking to us on follow-up evaluations and assessment.
Thank you very much. Very good afternoon. And I'll try my best to stick to the time. And so I just realized, in fact, I just made an edit on my first slide, that it's not training the trainers, but it's sharing with the trainers, because there aren't too many people to train the trainers. And also, all of you are experienced trainers. So I talked to Chitra about exactly what would she like me to talk about, and what exactly are we planning to do in this session. So it was supposed to be to train the trainers, but I think almost everybody has a lot of rich life experience if they don't exactly have it in this area. But it's a lot of common sense also. So I thought I'll just take you through literally the LVP model. So my topic was about the follow-up evaluations and assessments. So say supposing that with great hardship, they have come to join in for the fellowship and they have joined. And once they're in the fellowship, how do you evaluate them and how do you assess them and keep them engaged throughout? So how to assess? So I'm just restricting myself to the cornea fellowship, but it is pretty much true to most of the fellowships that we have at LVP or other places, that a fellowship is a structure that cannot be a purely formalized kind of a learning system. It's not like a management course or a school where you can give assignments and it's totally different and dynamic. But it has several components. I would say from the top of my head, it has a clinical component, which I mean both clinics as well as surgical, of course. And then it has academic. And then, of course, there's research, which we want our fellows to do. And you want them to be a good doctor. I think I would flip the order. And good doctor, I'm sure Himanshu, Avinash, a lot of us would agree that we want good doctor first and foremost, and then the other things will obviously fall into place. So like our chair always says, the 3 H's, you want head, hands, and heart equally for all our doctors, all our fellows who come out. So learners need endless feedback. They don't need endless teaching. It's not enough to keep on teaching them. So they need more of a feedback. And because they're very young, so they lack the experience or the insight. And I can give you an example of what I mean by insight. Insight means that very often we have fellows who have trained, and they may have had very strong component of cataract surgical training when they come for the cornea fellowship. So they feel they're very good cataract surgeons. And they say, oh, we know cataract surgery, now next level, we want to do the PK. But when you look at them, you see that they have learned a lot of bad habits. So they don't have the insight that they're not good surgeons. And that's detrimental for their training. So they have to unlearn the bad habits. So if they've especially picked up surgery elsewhere. Shreyash, you know that we keep saying that it's better to come in with a slate which is clean rather than a filled-in slate. So that's the only way you can follow the leader by these ducklings. So there is another concept of expectation versus reality. So when we want a passport photo, we really want it to look like this, but then it usually looks like this. So the expectation is when these 3 bars that I've put here, and is that we expect that our fellows should have about a 50% component of the clinical stuff, which is both clinics and surgical, and a very good, robust, at least 30% of academics. This is purely because of the time. In other fellowship, it can be balanced, but we have a very busy clinical workload, and at least 20% of research component. This is what, at least in the cornea fellowship, because of the time, effort, we want this. But what the fellow wants is maybe 90, I would say 99% should be clinics, especially surgical could be a good 78% of that 99%. One more example is very recently, we were in the interviews for the incoming fellows, and one question I asked is, what do you expect, why do you select cornea and why do you select LVP? So for cornea, they said, like Miss World answers, we want to do this one. But why LVP? It's because the surgical hands-on is very good. So that is like 0. So that's the incorrect answer. So the fellows want 99% of the clinics, and they want, academics, yes, but somebody else should teach it to them, and research, So probably the balance of that would be more about 70-80% of the clinical volume. That's because of the volume we have. We have a huge volume in all centers, whether it's private, public, wherever you look at. And also a good 20-30%, yes, academic sometimes does match pretty well, because thanks to our education initiatives from our education team. And sometimes you have a good balance of research also. This bar could be slightly different, but this is what we have in cornea. So this is the reality that we have. So coming to our fellowship model, as I told you, I'm just sharing the experience, not training anyone. So we have a 3-year fellowship. It has 3 components. It starts off 9 months with the basics, which is exactly what Dr. Basak said. A PG student can come in from any part of India, may not know even slit lamp. Certainly, I didn't know applanation. I had no idea how to do it. And indirect, I had barely done any. So the basics includes a 1-month robust getting experience with all these techniques, and then it includes cataract surgical training and various other components. Then, and they rotate through all the specialties as well as the core specialty. So they get a good hang of everything. So that 9 months is actually what you're trying to do is compensate for the residency. So this is literally what we're trying to do here, and make them independent for certain basic diseases to manage those diseases. And the next 12 months, they spend a year at a secondary center where most of the bulk is a lot of cataract surgery and basic training, basic diseases, and anything which is more than a basic disease, like say glaucoma or something, infection, they send upstream to the tertiary care center. And after they finish all this, they come back for the last 15 months for the core subspecialty. So if it's cornea, they come back to cornea, and the last 15 months is when they're totally into cornea. So this has been an excellent model, and we get very well-trained, robust fellows by the end of this, because imagine they've finished literally like a second residency, they've learned cataract surgery and they've done it and they've managed a center, and they come back and they go out with the subspecialty of the choice. So which means that it's a lot of multitasking, you have to do multiple things, you have an academic session, there's so much clinical work, there's so many assignments and research, etc. Clinical work comes twice because it's so much of clinical work. And we had a very good experience during COVID for the, not with COVID, but for the education aspect, in the sense that we had so much more education component because there was less clinical, obviously. But that slowly has, it cannot sustain that way, and we're slowly going back to our earlier amount of academics. The fellowship model is centralized, so we have an education academy. The entire team oversees the program. They tie it together. They take care of the basics, which includes cataract surgical training, wet labs, diagnostics, what have you. And also they schedule periodic assignments, rotations for the fellows. And they have a complex system of ensuring that the fellows keep on improving their academics by having them create content on various subjects. They also research and videos, etc. Coming to the level of the individual service, say cornea, for example. So the model we follow is we have a mentorship model, and we found this very successful. Each fellow is paired with a mentor. Mentor is one of the faculty members in that department. So either we can randomly assign the fellow and to the mentor, or more better is to have a deliberate assignment where we match what we think the personalities are like, and that really works. It's a very good handshake in that case. And the mentor has, just like a mentor would be, literally takes the fellow through the ropes, and the initial basic curriculum, like say it's corneal scraping, how to operate on simple cases, corneal perforation and things like that, are taken up by the initial mentor. And the basic curriculum in terms of reading also is covered by the mentor by giving assignments to the fellow, periodically assesses, helps them with wet lab and so on. So that each faculty has one fellow to really train, or it may be more than one, because every year you become a mentor. So 1 to 2 fellows at different stages that they have to train. So the burden of on each faculty is less, and the kind of handholding is better. The fellow connects. So this is the person my go-through person whenever I have a problem. So the fellow connects with that mentor. It really helps. And then in addition to this, we have monthly evaluations by the mentor and head of service one-on-one. There's an online feedback form. And as well as we have quarterly evaluations by the department with the fellows. So the entire department, as well as 3 or 4 fellows get together, one fellow with the entire department, and we give a feedback to the fellow, or the fellow discusses their problems and so on. So ultimately, the goal of this continuous evaluation and assessment is to course correct as required. So somebody has more already, you can push them more into research, more into academics, check more into innovation, or see where their talents lie, if somebody who's already very, very good. Whereas if somebody is not so good, then they need more surgical training. It could be more basics or stuff like that. And remember that when we train these people, at least for us, it's not just, that we're going to give a completion to any fellow. It's that the reputation of the institute is at stake. Anybody else who hires the fellow later sees the stamp of our organization and might just hire just based on that. So you can't send out somebody who's not up to the mark. So the goal is not to take punitive actions against the fellow. And even the best of fellows need to have a continuous engagement and feedback. This is what we have noted. Just because they're good, we can't just leave them alone. Then they'll not progress, or they may get complacent. So however, I would say that one big drawback is that the faculty has to be very, very involved and literally selfless, give a lot of time, at least to their mentees. So that is the commitment that the faculty has to have with this model. That's all. And I think all of this, as you said, you put out somebody who's so well trained, and that will help us in patient care. And we can hire those same people back with us also. Thank you very much.
Thank you. Thank you so much, Dr. Soma. Actually, it's LVP is a dream institute, and I think every mentee would always dream of being in an institute like that with such a structured program. So, and I wish all the hospitals, like especially the government hospitals all over the country, should follow such structured programs, irrespective of which department they are in, but at least they should get the good infrastructure and proper equipment and the right techniques for their fellows. Thank you so much.
Thank you.
Thank you. Dr. Samar sir, you want to say something?
Yeah, right now in the lunchtime, a girl come to me and said that I want to do fellowship. She is from some other state. So this question I asked every fellows during interview, that what is your plan for next 5 years? The answer actually depends on, this is, though I do not have any gender variation, but for girls and for boys, the answer is different. And I know some of the girls, they have done beautiful fellowship program. They went back to their place, worked for 6 months with some institute or colleagues, and again after marriage, they have shifted to some other place where there is no facility for cornea. Cornea is such a difficult subject. It depends on eye banking proper. So it is, though it is 15 or 20% of your cornea work, but that is the end product of your, you are just incomplete unless you do transplant surgery. So I feel sad for them. So I answered her that you first decide, then you do an application in my email. So this is maybe relevant for all institute, especially with keratoplasty, unless you have, because unless you have little bigger umbrella, you cannot do transplant surgery alone. There are only 1 or 2 examples in the country who are having individual transplant center.
Yes.
So that is the
Right,
thing I wanted to share.
Definitely, sir. Thank you so much. Sir, want to
Another
share
very
something?
important aspect which we have not covered is, see, most of these fellowships involve surgery, but not every trainee is cut out to be a surgeon. So many times I find that even after like 1.5 years of fellowship, there's some people who just cannot pick up surgery. However much time you spend with them, try to do it. So some are not cut out for surgery. So probably it's also the role of the mentor or the trainer to see as to who is cut out for that work. Otherwise, it's like trying to fit a square peg in a round hole, and it doesn't. Because see, in Europe, what they've done is they've clearly divided ophthalmology into surgical ophthalmologists and medical ophthalmologists.
Yes.
Because
I wanted to say that.
because they found in a study that a person who does like 100 or 150 cataract surgeries a year has much more complications than a person doing 800 to 1000 cataract surgeries a year. And a person who is doing 1000 cataracts can even do more with less complications. So they've clearly kind of divided. So you have non-operating ophthalmologists and operating ophthalmologists. I think even for the fellowship, we need to kind of look at who is competent for what.
But it would be a little difficult for the for the trainee to listen to that and to accept that fact.
But
it would be a little disturbing for that.
Another honest confession that cornea transplant is such a surgery. During fellowship period, everybody is euphoric, and when they go back to their practice and they do start cataract and refractive, they do not want to do the transplant surgery. I am telling you, in Kolkata city, there are 6 surgeons from Premier Institute. They have spent 2 years, 1.5 years, 3 years fellowship. When they come, दादा आपको पास भेज देते हैं, आप करो ना, आप तो बहुत करते हैं और एक बढ़ा लो. You do, I will supply the cornea. No, sir, उतना head में नहीं लेना है. So the transplant surgery is such, you have to take the whole thing in your head. Unless that commitment is not there, normally I say you are not fit for, you go. I say that my condition is I will observe you 3 months. If I feel that you are not taking responsibility, go back to your place. So that is true.
One of my professors, corneal surgeon, he used to say that, being a corneal surgeon, you have to be very philosophical, because you will have to face a lot of failures. You will get secondary glaucoma, you will get graft failure.
Yes.
It's not like cataract or refractive surgery. It's not everybody's cup of tea, because otherwise you get depressed, in the sense that you're not able to give the same kind of outcomes and this thing. So you have to be philosophical about it.
Sometimes we get very different requests also. When I was interviewing one student, he came from one of the states which is not having a very good health infrastructure, and he made it very clear, and he was already almost nearing 30, and he made it very clear, I am working in a charity hospital, and in our area the corneal problems are more, corneal ulcers and other things are more, and we don't have any trained corneal person there. So my mentor, my chief asked me to go and do a corneal fellowship, especially in this institute, so that the clinical volume is more. So I want to learn mainly that, and whenever a ulcer problem occurs, to do a keratoplasty. So he's made it very clear, my aim is not refractive surgery, not this thing, but I want to go back and I have to start a proper cornea clinic there.
So that's a very focused way of thinking.
Like,
That's so true.
Actually, we have to give preferences to such.
They say a good surgeon should have the heart of a lion, eyes of an eagle, and the fingers of a lady, but no gender bias here, but that's what they say.
Many of them
So
even
let's
change
go.
this. We have seen a lot of retina surgeons who are now mainly doing cataract and refractive. They have done
I think the
specialty in
glamour
retina,
is
but
more in cataract refractive, and that quick satisfaction of the patients in retina.
the money.
Yes.